Hi, everybody. Welcome to the AIM webinar series. I'm pleased to present today's topic is peri-procedural recommendations for patients with systemic mastocytosis. My name is Dr. Stephanie Lee. I'm a hematologist at the University of Toronto. And today, our main objective is to really provide you with a pragmatic approach to how to manage patients who are going for a procedure and how to give recommendations to the surgical team to optimize outcomes. And to achieve this objective, I'm so pleased to welcome our expert panel today, Dr. Patrizia Bonadonna from the Allergy Unit, General Hospital of Vicenza in Italy, and Dr. Matthew Giannetti at the Mass General Brigham in Boston. So thank you so much for joining us today. And we're going to present four real patient cases with some questions and some very fruitful conversation, I'm sure. So I'll get things started here with case number one. So this is a 60-year-old man with indolent systemic mastocytosis who has coronary artery disease and has been recommended to undergo coronary artery bypass graft surgery, or CABG. And the surgical team has reached out asking for peri-procedural recommendations, and the anesthesia plan will be general anesthesia. So just a few notes on the patient's past medical history. So this is the mast cell disorder is indolent. It's been confirmed on bone marrow biopsy. The KIT D816V is positive at a relatively high VAF of 15%. There was no other genomic abnormalities, no end organ damage. Serum basal tryptase level is about 60 to 70. Again, liver, spleen, bone, no end organ damage. Documented urticaria pigmentosa. The patient's allergy history includes anaphylaxis to naproxen, and the patient has long-standing rhinitis, brain fog, abdominal cramping, diarrhea, and some itchy skin. The patient has had a previous surgical challenge with a cholecystectomy, and the procedure was a laparotomy, and the patient tolerated that well. And for their indolent mastocytosis, the patient takes cetirizine, ketotifen, and avapritinib. So with all of that in mind, Dr. Bonadonna, we'll start with you. What sort of preoperative recommendations do you tend to provide the surgical team for someone going for major invasive surgery? So specifically, what medications do you ask the patient to hold, to continue, and which ones do you add?
Thank you, Stephanie. And my recommendation is, first of all, to continue the treatment of anti-mediator for mediator symptoms if the patient is sticking. And in these cases, we suggest a premedication with antihistamines and anti-leukotrienes before the surgical procedure. The normal guidelines suggest to provide the premedication the day before and 2 hours before the surgical procedure. But I think that the most important things, and I repeat that to all my patients, to have a good collaboration, a good relationship with the surgery, because it's important to explain them that the mastocytosis is not a disease, an indolent systemic mastocytosis is not a disease that always can provoke anaphylaxis during the surgical procedure, and to feel the surgery in a way comfortable, because the doctor have not to have afraid to operate these symptoms. But of course, the patients have to continue the treatment for mediator symptoms and to do a premedication.
And with the avapritinib in particular, you ask the patient to take that the day of the surgery?
Yes, unfortunately, in Italy, we don't have approved avapritinib, or only for aggressive form. And we know that in Europe, the other country can use it. Unfortunately, the AIFA, that is the control department in Italy for drugs, do not still approve this drug for indolent systemic mastocytosis. But of course, if the patients, because I know that in USA it's possible to use this drug, the patients have to continue these drugs, of course.
Perfect. Thank you. And so we'll move to you, Dr. Giannetti. So in the operative setting, are there specific things that you recommend to the surgical team? Sort of specifically, are some anesthetic agents, more likely to cause allergic reactions than others? Same with muscle, like paralytics. So if you can comment on that.
Yeah, a couple things. First off, thanks for having me. My pleasure to be here and talk to you guys about mastocytosis. So thank you, Stephanie, and the AIM folks. I think my answer here for this one is largely the same as Patrizio's. I think it's really important to have a discussion with the surgeon as well as anesthesia. I'm a little bit privileged to be in a large academic hospital setting where pretty much all of my patients with mastocytosis, I'll get an email or a EPIC using our electronic medical record message from the anesthesiologist saying, hey, we saw about this patient. What do you think? So in general, I don't have a strong preference for anesthetics or paralytics unless they've had an adverse reaction to one of them. I think generally I defer that to the surgical team. Of course, if somebody's had an adverse reaction to something, that's different. This patient in particular, a little bit tricky because they do have a reaction to NSAIDs. And so that's a kind of thing that often is not relevant immediately during the surgery, but post-operative pain control, we use a lot of NSAIDs. So a short conversation regarding that prior to surgery would go a long way after surgery. I would say one other thing just about the previous one. I do actually hold avapritinib prior to larger surgeries like this. This is a cardiac surgery. I think it's a cabbage, right? Forget the case. So for a bypass surgery, the Blueprint folks tell us maybe that we don't need to hold it. There is a bleeding risk associated with avapritinib. It's relatively mild, but for something like an open heart invasive surgery like that, I would probably hold it for several days beforehand, maybe 3 days beforehand. But otherwise, and I would inform surgeon, of course, with that. And depending on the type of surgery, this is the kind of thing that I would definitely want to talk to the cardiac surgeon. I don't know how they would feel about any medication that would lead to a bleeding risk, because people are often not often they're on pump for a while when they do these bypasses. But otherwise, yeah, I think that's a lot of talking, but I think that answers the question.
No, I mean, that's great, because that's really the spirit of the webinar, is that there's not always a right answer, and you're weighing the risks and benefits and individualizing these things. So that's great. And sort of your answer sort of leads us into the next question, which is, what kind of recommendations do you make in the post-operative setting? And analgesia, of course, is very important in mastocytosis, because uncontrolled pain can, of course, sometimes also elicit some of these symptoms. But if a patient has anaphylaxis to naproxen, and let's say they're having, what, Dr. Bonadonna, what do you typically tell the surgical team, just to try alternative analgesia, or what's your general approach?
First of all, I want to underline one thing. The allergy to naproxen is not a risk factor for the surgical procedure at all. Therefore, the patients who had a reaction with the antibiotics or with the other drugs do not have a high risk to general anesthesia drug used during the general anesthesia. This is the first point, very important, because the patients have to be relaxed, not afraid if they have problem. Of course, we can use, we could use anti-inflammatory drugs, analgesia during the operation, and so if these patients, usually we do before the challenge test for alternative drugs before the operation. But of course, if the operation is possible to schedule before, and if not, we can use the drugs. Different drugs, for example, paracetamol or other drugs who usually do not create problem in patients with allergy to naproxen. But it's very important to underline that the patients who had a reaction with other drugs have not to be afraid to undergo a surgical procedure.
Yeah, great. Thank you. Because I think that comes up a lot where patients are denied surgical procedures, or there's hesitancy. And I think the take-home message here is just because they've had anaphylaxis to one thing doesn't mean they're necessarily going to have it to other agents used in the surgical theater. And we still have to offer patients the standard of care. So thank you. So, what I'm trying to get here with this next question, Dr. Giannetti, is, does the patient's history of having allergic reactions change your recommendations to the surgical team, or do you sort of approach it under the impression that any patient with mastocytosis could react? Or, are you a little bit more aggressive in offering pre-medications if patients already come with a strong allergy history?
Yeah, it's a good question. I think, like Dr. Bonadonna mostly answered this question, the NSAID doesn't have a lot of bearing on the actual reaction intraoperatively. All of that said, I think the second point maybe is more important. Patients have a lot of anxiety, and the surgeons often have a lot of anxiety about these things as well. And so the things that I maybe would place more emphasis on would be the specific type of surgery, the specific type of procedure. A skin biopsy is definitely not equivalent to a coronary artery bypass. So in something like this, in a patient with anaphylaxis, I would probably pre-medicate with antihistamines, avoiding steroids. If they didn't have a strong allergy history, you could make the argument both ways. I mean, it would kind of be it's a very individualized discussion with the patient and care team. That's not a very data-driven answer, I realize, but I don't know that there's a right answer here. Giving somebody antihistamines preoperatively probably isn't going to cause any harm, and it's very low risk. By the same token, in a low-risk patient with really no allergy history, it may not do much. The other thing I would say is we're talking a lot about anaphylaxis, but many of these patients can have much less severe mild symptoms, just simply urticaria, flushing, other things like that. And having some antihistamines on board probably reduces the likelihood of smaller mast cell-driven symptoms like that.
Yeah, thanks for that. That's that. I think that brings up another point, is that it's not just the medications that the patient's being exposed to. There's also mechanical stimuli in the operating room. So, patients sometimes are put in a certain position, and there's tight, bands on them to hold them in position, and that can irritate the skin. So I think being thoughtful as well to the surgical team to try and not have a lot of, tight things on the skin, and are also, other important things that we can recommend. So thank you. And this is sort of in the same line, but if the patient, does the fact that the patient had a previous surgical challenge that was well tolerated, again, change your calculus, or it sounds like probably, the approach would be pretty similar? Okay, that's great. Again, I think you guys have already covered all these, which is wonderful. But if the patient was going for a less invasive procedure, so maybe percutaneous coronary intervention as opposed to CABG, again, would the degree of invasiveness change what you recommend, Dr. Bonadonna, or would you sort of have a similar approach?
I think that, of course, the more invasive procedure could be provoke much symptoms in the patients, but in any case, the suggestion that we give to the patients is similar.
Right.
Do not use. It's better to not use some drugs, for example, during the surgical procedure, because they can provoke a release of mediator from a cell, and on the other hand, there are drugs more safe, but more or less are the suggestion, the things that we say to our patients are the same. And I think that the most important point is to give this information before to the patients again. I say again, and in order to explain, to better explain the risk that is, of course, a risk slightly higher than in general population, but not so high as we thought 10, 20 years ago. The study are more. We know very well that the risk is not too high, and we have to speak with the patients and to explain them the risk. And speak with the anesthesiologist and the surgeon, of course. But this is my opinion.
Yeah, thank you. I think that's a really nice summary. So I'll move on to our second case. This is a 32-year-old woman with indolent SM who needs to have her wisdom teeth extracted. And the dentistry team has reached out asking you for medical clearance for the procedure. And they plan to use nitrous oxide and local anesthesia for the procedure. So the details of the patient's past medical history, indolent SM confirmed bone marrow. The KIT D816V is positive at 8%. There was no additional genomic abnormalities, no end organ damage, no cutaneous involvement. Serum basal tryptase level is around 20 to 30. The patient does not have HAT. The allergy history is anaphylaxis to honeybee venom. And otherwise, the patient has some intermittent cramping and diarrhea. She's tolerated local anesthetic in the past and also neuraxial anesthesia. And she is on famotidine as well as venom immunotherapy. So I'll start with you this time, Dr. Giannetti. So in the preoperative setting, are there any considerations that the dentistry needs to know about given the patient's undergoing venom immunotherapy?
No, I think these are spatially separate. So I think maybe the takeaway point is that the patient has a history of anaphylaxis. And so that should be noted and that is relevant. But the implications of somebody having a tooth extraction and being on venom immunotherapy, I think in a Venn diagram, probably there's no overlap between these two circles, I would say.
That's great. And do you routinely offer pre-medications for such a procedure like steroids or montelukast or additional antihistamines? Dr. Bonadonna, no. What's your typical? Okay.
For local anesthesia, no, absolutely no. And we shown that the risk of reaction during the local anesthesia is similar of the general population. In other words, very low, because also in the general population that we know that the patients thought to be allergic, also in general population, but instead the real reaction to local anesthesia are very, very low. And we know that we don't give any premedication to our patients when they have to go to the dentist. at all.
Perfect. Okay. Thank you. That's very helpful because I know at least my dentistry colleagues like very clear recommendations. So that was very clear. So thank you.
I think if I can chime in too, I agree 100% with what Dr. Bonadonna said. I think sometimes it's important to emphasize to both the patients and the care team. The patient just knows they're having surgery, but not all surgeries are the same. And so local anesthetic, it's really it's a totally different procedure than the prior patient who's having a coronary bypass. So a little bit of time to explain that particular nuance to the patient, I think, is really important.
Yeah, thank you. I think that so far a major theme is just good communication with the team doing the procedure, and good communication with the patient is really, first and foremost. I get this a lot where the dentist they ask, should this patient have the dental procedure done in a hospital setting versus community setting? What are both your opinions on that? What do you routinely suggest?
That doesn't matter much to me. I think hospital setting is not necessary for something like this. Of course, with the larger procedures, they do need to be in a hospital setting. A bypass, of course, that's limited to a hospital for a variety of other reasons. But I would be comfortable with either in this setting. Dr. Bonadonna, do you have thoughts?
I'm agree with you, Matthew. Usually, we don't suggest the go to the dentist in hospital, but there are some people, because we know patients with mastocytosis can have a release of mediator only because they have anxious, they have afraid. Therefore, if the patients go to the dentist outside the hospital could provoke anxiety, I suggest to go in the hospital. And I think that all the group who have patients with mastocytosis, the multidisciplinary group, have to be a good relationship with the dentist in the hospital in order to provide to the patients and minimize the risk of anxiety and therefore the release of mediator, to provide a possibility to have the procedure, the dentist procedures also in hospital. But if the patient is calm, for example, this is a typical patient that I have every day. There's these patients who have hymenopteral venom allergy, who they have mastocytosis, but they have not symptoms, other symptoms apart of the anaphylaxis to venom. And these patients are very calm. They usually do not have problem when they have to go to the dentist. But if we have patients with the systemic mastocytosis, very anxious, with them afraid, in my opinion is to suggest to have the procedure into the hospital.
Okay, thank you. And I think, again, the theme is individualizing it. So, yes. Just using patient factors and what you think is going to help the patient get through the procedure is really kind of the most important thing to focus on. And so we've talked about postoperative setting analgesia. I think you guys have already answered that very thoroughly. So I will move on to the second question, which is, how do you formulate your language when you haven't, a colleague ask you to clear a patient? So a lot of times, they want a written letter, or sometimes they just want you to tell them over email. But, how do you, just from a pragmatic perspective, how do you respond when you're asked to clear them? And this is for both of you.
I can go first. So we get this a lot. We have a lot of patients with SM kind of scattered throughout the United States. So I have essentially two templated letters that I will use. One is the least common one, which is the higher risk template for patients with, a history of severe anaphylaxis or a lot of anaphylaxis or undergoing higher risk, largely invasive procedures. And then, I will send that over. Basically says pre-medicate with how we talked about before. Most of the patients will get the other letter, which basically says this person has a clonal mast cell disorder. There is some variety in terms of adverse reactions, and they can be precipitated by a variety of stimuli, often anxiety, as Dr. Bonadonna nicely said. And for the low risk procedures, that's actually more of my concern, is anxiety from the patient as opposed to anything else. So we send that, and for people that are local, I will pick up the phone or send a message to anesthesia. But I guess to answer the question more directly, to clear a patient is, you should treat this patient like you treat anybody else. I don't want you to be afraid of anaphylaxis. I don't want you to be afraid of an allergic reaction. If it's higher risk, we're going to pre-medicate and mitigate that risk. But for most patients, there's really no difference other than you should, be aware of hives, flushing, have eyes on the patient's skin, things like that, and treat if something arises. But that it's, statistically more common that this is going to be a normal operation than there's going to be some kind of adverse reaction during the operation.
That's wonderful. Thank you. Dr. Bonadonna, do you have anything to add?
No, I'm perfectly agree with Matthew.
Perfect. Thank you. That was really succinct. And I think, I think that'll be helpful for a lot of our colleagues to hear how you approach that, because I think sometimes there's some nerves on everyone's anxiety for everybody. So I think that was really nicely put. So thank you. So I'll move on to case 3. And sorry, I should have said this at the beginning, but for our listeners, please, we'll take questions at the end. So if you have any questions for our expert panel, please put them in the chat and I will read them aloud at the end. Okay, case number 3. So we have a 30-year-old woman with indolent SM again, who has recently started a job in healthcare, and she is required to have the COVID vaccine. So she presents to your office wanting to know if you think it's safe. Oh, it shouldn't say influenza. Well, she probably needs that too. She needs to get some vaccines to work in healthcare, and she wants to know if it's safe for her to do so. Sorry for that typo. So again, this woman has indolent SM. She has D816V that's positive at a lower VAF, no additional genetic changes. Again, no end organ damage, high serum basal tryptase level at 72, no end organ damage, has urticaria pigmentosa, does not have HAT. This patient also has anaphylaxis to honeybee venom and penicillin, and has some, ongoing itchy skin, flushing, and diarrhea. She's never had a surgical or anesthetic challenge before, and her medications are listed below. So, vaccines in patients with mastocytosis. So, Dr. Bonadonna, I know this is an area of great interest for you, and this is a question I'm sure you could answer for a long time. But in general, what is your sort of summary, high-level summary of the evidence for serious allergic reactions to common vaccines in patients with SM?
As we shown in our study, that is very similar to Professor Castell and Matthew study, we show that the patients with systemic mastocytosis are not a high risk of reaction to vaccine. A practical example was the vaccination for COVID-19, that we, at the beginning, we didn't know how these patients could react at the vaccination, and we decided to vaccine patients in the hospital and with the premedication. Instead, our patients with mastocytosis had less reaction than the general population who had vaccination not in hospital but in other setting. So the risk of reaction is very similar to the general population. In this particular case, of course, the patients had symptoms related of release of mediator and take a lot of drugs for anti-mediator therapy. And so we can, of course, say to continue the therapy that they take, and in that case, we perform the vaccination in the out of hospital, in particular setting that usually we use for vaccination, and only to suggest to stay 30 minutes after the vaccination in that setting, but no other recommendation. I don't know if Matthew is agree with me, but this is my opinion.
No, I agree mostly completely. Some nuance, I think, depending on, you're right with a lower rate with antihistamines. We looked in patients across the United States, and it was in collaboration with Karen Hartman. So we had a healthy dose of people from Switzerland as well. And many of these people did not pre-medicate. Ours was slightly higher, but again, they had no pre-medication. Overall, though, the summary is it's very similar to the general population. And, these people are going to get sick if they get the actual COVID virus. And so if you look at it strictly from a risks and benefits standpoint, I think it's pretty clearly in favor of benefiting from vaccination. I do think some of the takeaways I would do from Dr. Bonadona's work is we do pre-medicate our patients nowadays. So we just have them take some antihistamines before vaccines. I will say there's not very strong data for this, but I think it does make people feel better, and it probably does reduce the incidence of hives and other things like that. Again, I don't have a lot of strong data for these claims, but again, in terms of risks and benefits, very little harm with a dose of antihistamines prior to vaccination. And so it does make people feel better. And I think it probably does provide some level of protection. So that would be my vote. I would also acknowledge, we have a largely limited data in this zone here. So a lot of this is going to rely on personal practice, and there may be regional variations, et cetera.
And when you, just to close the loop, when you suggest pre-medications, do you recommend 60 minutes before the vaccine? Or what do you say specifically to the patient?
Take a Zyrtec an hour before the vaccine.
Yeah. Yes. Okay. The same.
Okay, perfect. Do you think, and is there any evidence that live versus attenuated vaccines carry a different risk, or do you approach these the same?
The same.
Okay.
Yeah, that's we don't give a lot of live. I mean, MMR, yellow fever are the ones that I think of. Maybe MMR is more relevant for kids, but I would do the exact same. Yeah, sorry.
Okay, and you guys are already ahead of the game, have answered that question. Again, Dr. Bonadonna you guys already touched on this, but you tend to ask the patient to stick around for about 30 minutes or so after the vaccine. So that's wonderful. And this coming from a hematologist to allergist, do you, because I get this question sometimes and I don't think I have an intelligent answer often, but is there a need to check titers? Do patients with mastocytosis mount the same response, or is there any data to suggest that there's any issues there?
No,
Perfect.
Checking titers. So Dr. Orfao in Spain actually has some evidence, maybe to the contrary, that patients have different IgG responses to a variety of things, and that the IgG production is different in folks with mastocytosis, spatially separate from vaccines. But even in the general population, we use titers, but there's lots of people who don't produce good titers and appear to have good responses and protection from infection. So I don't think titers are going to be clinically useful in any capacity in mastocytosis patients specifically.
Okay, that's wonderful. Thank you. And there's just to supplement some of the work that you guys shared of your own work. There's just a slide here that we have. This is a retrospective review of 259 patients. This is at the University of Michigan with mast cell disorders who got the COVID vaccine. 18 of those patients had received the COVID vaccine, and the majority of them had the Pfizer vaccine. And most of these patients had taken at least one antihistamine within 30 minutes to a day prior. And the breakdown of patients included here, most of them had indolent SM. The tryptase ranged from 2 to 136, but most patients had a value around 40. And 4 of these 18 patients, or 22%, did have a prior history of anaphylaxis. And what this group found is that none of those patients had any documented unexpected reaction to the COVID-19 vaccine. So just a different study from the ones that you guys shared of your own work, supporting exactly what you said. And I just wanted to include one study looking at children specifically. And this is a retrospective review of vaccine reactions in patients 18 years or younger. And there was 94 patients here. This is the group at the NIH that did that. Most of these patients had cutaneous mastocytosis, but 20%, about 22% had indolent. And they estimated about over 2,000 vaccines had been given to this population. And there was only 11 unexpected reactions among 10 patients in this cohort, and 1 had anaphylaxis. There were 5 patients within this cohort that had a history of anaphylaxis, and those patients also did not react. They also looked at whether the tryptase level was predictive of those who reacted and didn't react, and there was no clear correlation there. So this group summary of their work was in keeping with what both of you guys have also shared, that the risk of anaphylaxis in this patient population is low, but out of an abundance of caution, it's still prudent to observe them for a period of time after.
Yes.
Okay. So just to supplement, but all these messages are kind of in unison, which is great. Okay, this is our last case. So this is a 40-year-old man with known indolent SM and concurrent hereditary alpha-tryptosemia. And the patient presents to the emergency room with what seems like an acute abdomen, a fever, and some, evidence of SIRS and sepsis. The emerge physician pages you and says, this patient needs a CT with IV contrast. Is it safe for me to give it to the patient with their known history of mastocytosis? And again, indolent SM confirmed on bone marrow, no additional genetic changes, no end organ damage. The patient does have urticaria pigmentosa, known HAT, has had anaphylactic reaction to honeybee, and also atracurium previously, has some vomiting, diarrhea, and hives to ibuprofen, alcohol, and morphine, has had a previous surgical challenge with an appendectomy that was well tolerated. And again, you can see the medications there. So our questions, my questions for you is, Dr. Bonadonna, if you could, again, share your experience in some of the data for the evidence of having serious allergic reactions to IV contrast agents.
This is a very challenge point because until several years ago, we thought that patients with mastocytosis could be at high risk if they undergo to the radio contrast media tests with the radio contrast media test. Instead, there are few data about published data about that, but and the data are with serious cases, not study with prospective study, are only case serious. And based of that, we suggested to our patients to take a premedication with antihistamines, with steroids, and with proton pump inhibitors, because in Italy, unfortunately, we don't have ranitidine, and We suggest proton pump inhibitors because the amount of steroids during this premedication is very high. Therefore, the patients can have problem for the intake of steroids. But I don't know the opinion of Matthew, but in Italy we are with the Italian Rete Italiana of Mastocytosis is the group of doctors who study together. We have a register in Italy regarding the mastocytosis. We are doing a prospective study about this topic, and the preliminary data is that the risk is not so high how we thought some years ago. But until we do not have this data published, we have to suggest the premedication of these patients. But it is also very important to explain, like for surgical procedure, to the patient and to radiologist, that the risk is not so high. Only in patients who had the reaction before, of course, like in the general population. And but at the moment, I suggest the premedication. I don't know the opinion of Matthew. This is my behavior.
Yeah, I think I agree mostly. I do. It sounds like less pre-medication than you. There is some data for it. I think there's also a practical concern here for us. So our radiology, if patients have certain conditions, will sometimes block patients from having procedures, or they'll page, or they'll say, we need to speak with your doctor. So the reality is, I think, initially, this was thought to be high risk, as Dr. Bonadonna said, but it was mostly dictated by a series of case reports without larger scale studies. We do now have a medium-sized study. I forget, it's a couple of years ago, maybe a year or two ago, which had actually no allergic reactions to contrast in patients with mastocytosis of over 100 and something contrast administered. So my practical policy is that I will tell patients that they do not need pre-medication unless they, one, have a history of severe anaphylaxis, or two, have a history of prior contrast reaction, in which case I will pre-medicate. Otherwise, I make sure to talk to patients. And a lot of times, though, truthfully, radiology says, well, we're not comfortable doing this examination in this patient. I will say, take some antihistamines, wait 30 minutes, and get the scan. But that practical consideration is sometimes unfortunate. But, in all situations, you want the patient to be able to have the scan. I would say one final thing. In this situation, this person is sick, right? They're febrile, they're neutropenic. I would not give steroids to this person. I would simply go in and scan them.
Yes, we have. Sorry.
No, please.
We use the corticosteroids because we have the guidelines shared with the European group of drug allergy, and but we have to update this guideline, and we are working on that, and the guideline now available say to do a premedication with the steroid. I'm agree with you, Matthew, that probably is not necessary to do that, but we have to change the guidelines now.
Thank you for that. Do you think there is a difference in risk if it's administered IV versus oral contrast? Dr. Bonadonna, do you have a view?
I think the risk is low in any case, but of course, I think in AV the risk is higher than oral intake of the radiocontrast.
Dr. Giannetti, do you feel similarly?
I agree. It's never been looked at in mastocytosis. There is a small little study that looked at it in in the general population, and they found that the oral contrast risk is lower. This is general population, though, but you can reasonably extrapolate that to patients with mastocytosis. But I think Dr. Bonadona's point is that the risk overall is probably pretty low.
Right, low in the first place. And what is your opinion about the types of contrast agents, so like iodine versus gadolinium? Is there any data to support one is less prone to cause reactions than the other?
I think that the paramagnetic agents are a less risk of reaction than the iodine radio contrast.
Okay. And do you, Dr. Giannetti, do you think the risk of reacting in general is higher among patients with indolent SM versus advanced SM?
Yeah, I think it's very patient specific, but I do think, at least in my head, indolent SM is more a disease of mast cell activation, and advanced SM is more a disease of mast cell proliferation.
Right. Yeah, that's perfectly succinct. I think we've already covered the pre-medications, so thank you. I just do want to touch before we move on. Does concurrent hereditary alpha tryptosemia change your calculus in any way, or are you approaching these similarly? Dr. Bonadonna, maybe I'll go back to you for this one.
This is a very topic point because we thought, and that there are studies from NHA, from Jonathan Lyons, that the heart could be a risk factor. At the beginning, we thought that the heart could be a risk factor for the allergic reaction in general. Instead, the new paper, especially from the Spanish group, confirmed that the heart do not modify the recommendation at all. The risk is the same that the patients without heart, in my opinion.
Agree.
Okay.
Yeah, I don't have much to add.
Thank you. And this is just touching on some of the studies that you both brought up while we were speaking about this, just to summarize. So this is a retrospective study looking at the safety of contrast dyes in systemic mastocytosis. And there's 162 patients. There was a decent breakdown of ISM and advanced SM. Previous contrast-induced hypersensitivity reaction were documented in 4 of these patients. So most patients had not had this reaction to contrast in the past. And the patients underwent a total of over 300 contrast media enhanced imaging studies, both CTs with iodine-based contrast and gadolinium-based contrast. And among this cohort, only 3 patients had been given pre-medication. And like you already summarized, Dr. Giannetti, none of these patients had a documented contrast-induced hypersensitivity reaction among this cohort. And just to speak about guidelines, like you brought up, Dr. Bonadonna, that, I think there's been a lot of different guidelines and some different groups making different recommendations. And in this consensus statement here from the American College of Radiology and the American Academy of Allergy and Asthma Immunology, they had a task force together to sort of try and harmonize the recommendations in general for hypersensitivity reactions to iodinated contrast media. And really, they define pre-medication as giving corticosteroids plus or minus antihistamines. And so this is just in patients in general. And so if a patient has a history of a mild reaction in the past, they do not recommend pre-medication, even if there was a mild reaction in the past. In a patient with a moderate previous reaction, again, the pre-medications can be considered, but should be individualized. And then a patient with a severe reaction to contrast media, premedication is recommended. And if a patient has a severe reaction, they do recommend it be given in the hospital setting. And then they go further in this statement they do bring up mastocytosis. And I think, the language here is really saying patients who've had previous high-risk serious anaphylaxis reactions or have comorbid conditions like mastocytosis that imply a greater risk for more serious reaction, this favors giving pre-medication. But I think this is really, again, hinging on, they've reacted before. We acknowledge that mastocytosis might increase that risk a bit more. So there is some steps forward into kind of updating the recommendations for contrast. So that will bring us to, we have 4 minutes left. So I will take some questions from the audience here. Okay, so we have a question. Are there any specific recommendations for pre and post treatment of patients receiving Prolia or other types of medications for osteoporosis? What are your opinions on that? Great question. Or what about blood transfusions? Let's put them both in there. Maybe Dr. Bonadonna, I'll start with you.
Denosumab, the Prolia is denosumab, is a drug for osteoporosis, and biphosphonate could be more dangerous in case of, for example, dentist surgical procedures. But we suggest do not do Prolia. Usually we give Prolia every 6 months, and therefore it would be nice to have the surgical procedure immediately before the next injection, not in the 3 or 4 months after the injection. This is the suggestion that we provide to the patients, especially if the patients have to undergo a dentist procedures but these are the recommendation, general recommendation for Prolia. For biphosphonate is more dangerous than bisphosphonate, and therefore we suggest do not give biphosphonate if they have problem with their the dentist problem. I don't know.
Do you suggest they take antihistamines before getting Prolia or?
No,
Okay.
Absolutely not.
Okay.
Absolutely not. No, I understood that the question is if there is problem if they take Prolia to perform the surgical procedure, because yes, the answer is yes, especially for dentist problem, they do not have to have surgical in the mouth immediately after the injection of Prolia, but the Prolia is not necessary to take antihistamines before.
Oh, perfect. Dr. Giannetti, do you have anything to add?
No, I agree with that. I mean, I think it wasn't clear to me what the question was exactly asking, but if it was adverse reactions to Prolia, I agree with Dr. Bonadonna. Reclass is actually the worst for adverse reactions. People can often feel terrible for a couple of days, but I have never pre-medicated or done anything specifically to address mastocytosis prior to those injections.
Perfect. Thank you. I hope that answers the question. We are running out of time. I'm sorry. But I just wanted to close things out and of course, thank our expert panel, Dr. Bonadonna and Giannetti, for such a wonderful conversation. I know I've learned a lot, and I think I'll take a lot of this with me. I want to thank Dr. Chernak, who contributed to some of the content, and Dr. Gottlieb, and we want to thank our sponsors, Cogent Biosciences, for their support. So thank you all so much for joining. We will see you at the next AIM webinar next quarter. And thank you again.